Dr. McPherson has maintained a practice in both hospice and ambulatory care her entire career. She teaches extensively in the Doctor of Pharmacy curriculum on pain management and end-of-life care, and she developed one of the first and few palliative care pharmacy residencies in the United States. Dr. McPherson serves on the board of the Hospice Network of Maryland and is a trustee of the Society of Palliative Care Pharmacists. Among the many honors she's received are the Presidential Citation from the Hospice and Palliative Nurses Association.
So as you heard, I'm a pharmacist, and I've practiced in hospice and palliative care for about 30 years now. So I'm all about the drugs. I believe in better living through and better dying through chemistry, so that's kind of where I live. Rock on. But what I'm really passionate about is appropriate drug therapy at the end of life. Not too much, not too little, but just the right amount of drugs and the right drugs for the right indication for the right patient. I think we still have some room to grow in that area. I think an important thing is often practitioners in end-of-life care don't want to grasp the fact that not all physical symptoms are amenable to drug therapy, or not all complaints that the patient has are amenable. For example, I often have to point out that not all types of physical pain are opioid responsive type pains. Perhaps the patient would do better with a steroid or a co-analgesic of another sort, for example. If you consider the three trajectories toward death, I think there are three we could consider. The first is the American dream. I want to live flat out till I'm 90 and then have a fatal MI in the middle of the night. What do you think? Who's with me on that? Yeah, that's the way to roll. I don't even want to know when it hit me. The second is a slow decline from frailty or dementia known as failure to thrive, although Medicare has informed us we are no longer allowed to fail to thrive. Apparently we have to thrive right up till we die. So that's one. And then the third is really the postponement of death, thanks to the last 20 or so years, the advancements in anti-cancer therapy and all these implanted devices that we see in heart failure patients. So people are living longer, but sort of knowing what's in store for them. So they are facing this eventual terminal decline. And this advanced illness model actually brings, paradoxically, the potential for existential distress and suffering. And I see this a lot in end-of-life care. Patients have a lot of time to ruminate and even perseverate about what's in store for them. How will I die? Who's going to see it? Where am I going to be? What's going to happen to me? And obviously, this can lead to a lot of anxiety and depression. I know I'm a professional catastrophizer. If I get a headache, I go right to brain tumor. I do not fool around. So I think that's a professional hazard. Why fool around? Come on. Motrin won't fix it. I think someone earlier today mentioned Dame Cicely Saunders, who is absolutely my hero. She is the founder of the modern hospice movement, and she really promulgated this concept of total pain. So it's not just the physical pain, it's the psychological and the spiritual and so forth and so on. So I think that's so true. And in preparation for this, I actually did a little research on existential distress. Probably the gentleman to my left could do this in a coma, but what I found was the 6 different categories on existential distress. Death anxiety. Oh my gosh, that is like a condition of participation in hospice. I mean, you pretty much have to be wired for sound. Loss, change, and grief. Freedom of choice, that kind of goes away. Dignity of the self, fundamental aloneness, altered quality of relationships, meaning, has your life had meaning, and the mystery. And the authors were quick to point out this is not a psychiatric illness, this just arises from the universal challenge of being a human. So we've been talking about stories all day, so I'm going to conclude my 5 minutes with a story. We had a patient several years ago in hospice, a woman who was 37 years old, who had a really horrendous head and neck cancer. It was really awful. It was just awful. So she had 2 questions for her physician. How will I die? What will that be like? And her other big worry is she had 3 children under the age of 10. She was divorced, and she suspected her ex-husband of sexually abusing the youngest little girl. So her physician said, in a very kind and empathetic way, of course, well, you're either going to bleed internally, all your blood, or you're going to bleed out all over the place, or you're going to suffocate to death. Well, thank you. That was so helpful. Somebody missed the empathy class. Thinking about how am I going to die, and are the kids going to see it, and what's going to happen to the kids when I die, and is, my ex-husband going to, do something he shouldn't be doing. So she would have the most amazing anxiety attacks. She would get tachycardic, she would have dyspnea, she would suck all the air out of the room. She was a red-hot mess. And the hospice nurse case manager kept calling me saying, come on, I need a drug. How about Ativan? How about Xanax? I was like, come on, you might as well give her Skittles. These drugs are not going to fix what she is going through. And indeed, me, the drugs did not help. My only suggestion, had I known about psilocybin, my only suggestion is, can we call the God Squad? Get the chaplain in there, the social worker, and maybe some psychosocial support for this poor woman. And it was a mess for a long time, and eventually it kind of got settled and worked out. But this is an example of one of those times where drug therapy, at least traditional drug therapy, is not the answer.
Well, that's a pretty eloquent statement of the need we're facing. Thank you.